Clinic. Stacey, welcome to SADS Facebook Live.
Thank you very much. I'm very excited to be a part of this.
I've been looking forward to this program for a long time. This, for those of you who've been with us from day one, this is our 21st Friday together. We started doing this since March when the COVID-19 pandemic came upon us, to try to answer questions and meet your needs for those of our families out there with genetic heart rhythm diseases. And so on behalf of Alice Laura, the CEO of the Sudden Arrhythmia Death Syndrome Foundation, and myself, Mike Ackerman, here at Mayo Clinic and the president of the board, thanks for joining us. We've had over 70,000 views from you all out there, and we're so glad that we've been able to meet a need. Today's program is not about genetic heart disease, it's not about SADS conditions, it's about the state of affairs of SARS-CoV-2 and COVID-19. And this is why I've been looking forward to it. Stacey is one of my favorites at Mayo Clinic.
Likewise.
I'm one of her medical school classmates. We are class of 1995 Mayo Clinic Medical School, and Stacey and I are next door neighbors. So, Stacey, this is really special. I would say this is a bit of a sobering week from COVID-19. I saw that we just crossed the 4 million mark for cases in the United States, that the United States comprises 25% of all worldwide cases, which are at 16 million. In the US, there have been over 144,000 deaths. We were in this good state in May and June when they were, for like 6 weeks, we were at 20,000 cases a day. Then June 26th forward, we've been at 40,000 cases a day since June 26th. And worse, since July 7th, for the last 17 days, we have exceeded 60,000 cases a day in just the United States alone. Stacey, can you react to those stats a little bit and tell our listeners kind of what's going on in the epidemiology of COVID-19 right now?
Well, that's a great question. And thank you again for having me be a part of this discussion. I think it's wonderful when people are interested and engaged in learning and contributing to our knowledge about COVID-19. I think the perfect word, Mike, is the word you use, which is sobering. So at the beginning of the epidemic and then pandemic, there was little knowledge about how to control the infection, how to treat the infection, what the mechanism of transmission was. And as a result, it was essentially just moving through states, countries, and continents like wildfire, because we just didn't know. And so the response was to quarantine quickly until we understood more about the transmission and the virus itself. So we're fortunate that we now do understand more, and we know measures that will stop or dramatically decrease the transmission of the infection. And those are universal masking whenever you're in a public indoor space. So if you're out walking your dog, you don't need to wear a mask. If you're in the bank, in a grocery store, or an indoor place with other people, you absolutely need to wear a mask. We know that social distancing of at least 6 feet or more is important, and that's because of the mechanism of how this virus is transmitted. We know it's transmitted through droplets, which means if I have the infection and I cough or sneeze, my droplets can go just about 6 feet. And so it could land on a person if they were standing within 6 feet, or if they're not, but a countertop is, it could land on that countertop. And then later a person could touch that countertop, then rub their nose and auto-infect or self-infect. So if high-touch items are cleaned regularly, people are standing at least 6 feet apart, and they're wearing masks. So if I sneeze, it's actually not even going to go at all. And if you wash your hands, so even if you touched a doorknob or a surface where it existed and you washed your hands before you take your mask off, you're fine. We know those 3 measures work.
Stacey, with those measures, let me ask you, and I forgot to tell Facebook Live land for SAD, you know what, besides Dr. Rizza being my neighbor and me being her medical school classmate, she is also Mayo Clinic's expert in COVID-19. She's an infectious disease specialist, and she and a little known fact, her husband, Dr. Andrew Badley, are charged as two of the leaders for the entire Mayo Clinic enterprise for COVID-19 and some of the COVID-19 related trials. So I didn't invite her on just because we're neighbors.
Because I'm a neighbor.
She is the person. So what she's saying is true knowledge. And that's the reason we're doing this today, is to separate out fact from fiction, hope from hype, and put it. And with what you just said, Stacey, if I'm doing all those things right, I'm masking, I'm washing, I'm staying apart, what's my actual chances of getting COVID-19 or getting the infection, getting infected with the virus in the state of Minnesota, for example? Is that a 1 out of 2 chance? Is that a 1 in 500 chance? Is that a 1 in a million chance? What's kind of my actual chances if I'm doing things right?
That's a great question, Mike. And I know everybody wants to hold on to that number, but it's almost impossible for me to give that number because it so much depends on the environment and on the behavior of the person. And the example I will give is Minnesota is a fairly low incident state. We certainly have COVID, and we still are dealing with good numbers of COVID infections and COVID admissions to the hospital. But compared to many parts of the country and the world, we're actually not that bad. But the majority of the infections are happening from people's social environments and their gathering. So even if you're doing everything correctly, but you go home to a house that has 14 people in it and 13 of those people are going to bars, then that could increase your risk. If you live with 2 other people and you're not great at those measures, then that could also increase your risk. If you live in a home setting where everybody is being respectful of the measures, whether it's 2 people or 14 people, everybody's masking, everybody's avoiding these large congregated areas, everybody's cleaning their hands, everybody's being respectful of the measures, then your risk is very low. And that answer is accurate whether you live in Dade County in Miami, in Houston, or whether you live in Olmsted County in Minnesota. So if you live in those other places, your opportunities are higher that if you go to a bar or go to a place, and don't follow it, you're probably more likely to get it than in Minnesota. But if you're following all the correct measures, you're safe. If you're not in Minnesota, you're not safe.
That's great, Stacey. Another thing that I think is we needed to do as an organization is when it first broke out and a paper came out, I think in February, March, saying if you have heart disease, you are at great risk of bad COVID-19. And our SADS family started saying, well, is long QT syndrome heart disease? Is Brugada syndrome heart disease? And we had to step in the gap and say, wait a second, that's not the risk. Your heart disease is not the at-risk heart disease, and give them the good news that the chances of having bad COVID-19 because I have long QT syndrome is actually no different than if I'm a 19-year-old with no conditions whatsoever and I'm otherwise healthy. But over the last 4 months, I think we've learned, haven't we, what are the setups for bad COVID-19 and who's at greatest risk. And maybe we should tell our listeners who are the at-risk people, because there's a lot of confusion out there, it seems.
Yeah, that's, again, a great question. And it's something that's important for everybody to understand. We do understand far better now than we did 4 months ago on who is more likely, if they get sick, to have kind of a viral syndrome, who's more likely to end up in the hospital and who's more likely to end up in a vent. And that's really what we care about. We care about whether somebody has a bad outcome from the infection. It's not a perfect science, but we do know that people who have underlying heart disease, and as you said, Mike, there are forms of heart disease that can put people at risk. It's not the arrhythmias, but there are other forms of heart disease that could put people at risk. Lung disease, COPD, chronic smoking is a risk factor. So if you are a smoker, you are at risk because of the impact it has on your lungs as well as the immune system. Chronic kidney disease is a problem. Untreated diabetes, but not, we're actually finding it's not the type 1 diabetics who have the greatest risk, it's the type 2. And that very much relates to the other risk factor that just keeps showing up time after time, and that is obesity. We have seen that all over the data from China, from Italy, from France, all through Europe, and we've seen it repeatedly in the United States, that a BMI over 30, and that's not a hunked up, muscled person, that because BMIs aren't a perfect measure, but a BMI over 30, particularly BMIs over 35 to 40, whether you're 19 years old or 60 years old, is a independent risk factor for people getting very bad outcomes if they get infected. And we have seen that it's actually an even more dominant risk factor in some very large studies than immunosuppression. That in fact, in many studies, the immunosuppression, depending on the kind you have, really wasn't a factor at all, but obesity by itself was.
I love that, Stacey, when you shared that with me about immunosuppression, because as you know, our oldest son has Crohn's disease and he takes Remicade every 6 weeks. And when you shared that with us, that was a huge relief off our shoulders, because he certainly is lean and a lean, mean fighting machine otherwise, and not obese. And really, I think the obesity issue, we as healthcare providers and the community out there, it's time to lose weight. And it's time to get in shape, and it's time to take this downtime and more free time than we've had before and say, it is time. I have got to change that number on the scale. And even if you start losing pounds now, it's better. And because you said obesity is really one of the big, big bad ones, right?
We see it frequently. And I think we see that as somewhat good news and bad news. So the bad news is that much of Western Europe, Scandinavia, United States, Australia, New Zealand, North America, Canada included, many of our societies, unfortunately, we're in a state that we have far more obesity than we ideally would want, which means there are more people at risk. But the good news is this is a risk factor that you can change. That's great news. And it also tells us that even in the other areas, in addition to taking care of your health, it goes even farther beyond just losing weight. It's treating your high blood pressure. It's making sure you're paying attention to the diabetes, getting your glucose checked if you haven't, and finding out, do I have type 2 diabetes? Does this need to be treated? Quitting smoking if you haven't is also a large risk factor and could help improve. I mean, you should quit smoking for many reasons, but in this sort of immediate world, help improve your outcomes should you get a COVID infection. But absolutely losing weight will be important.
And I think we need to tell our patients that. In fact, yesterday I saw a gentleman with type 2 long QT syndrome. He was so worried about COVID-19, and yet he's been a chain smoker for 35 years.
Yeah.
And his BMI is 35. And I said, how much weight are we going to lose? And when are you going to declare for me your quit date for smoking? Because we can make a difference, and our patients can improve their health status by taking the so-called bull by the horns. And do it.
Exactly. Absolutely.
Stacey, I was wondering about, I remember back in February, March, when we were seeing the pictures in northern Italy and New York, as New York City was sort of getting overwhelmed. And then we were talking about running out of ventilators and needing to now change car factories to ventilator factories and all this. And then something kind of amazing happened. I mean, we went from being told that if you get hospitalized because of your viral infection, and now you have symptomatic COVID-19, and if you get put on a breathing machine, a ventilator, you basically are almost at a death sentence. It was something like a 50 to 75% mortality. And now the case fatality rate for this virus is in the like 1% territory overall for this. What has happened there? Did we just get smarter? Did we start getting a handle on the virus? Did we say, okay, if a system gets overrun, like northern Italy did, then it sort of overwhelms the system and you die. And if it comes in at a trickle, we can figure this out and manage it well. What's some of the reasons behind this success story? Because I think this has been a huge success, that this virus isn't near as deadly as what it first seemed to be when it came on the scene.
So there's a lot of meat on that bone. And so I'm going to chip away at several points that you brought up. And I'll start with the very last one, is the virus doesn't seem as deadly as it originally was. And that is partially because of our testing ability. So at the beginning of the pandemic, we did not have the ability to test large numbers of people, including asymptomatic people or people with mild disease. We were literally testing only people with significant disease who were about to be admitted to the hospital. So it artificially inflated the death rate. Now that we're able to test people who are infected, who are asymptomatic or have very mild symptoms, we realize we have a better denominator, and the death rate is much, much lower than was originally reported earlier in the pandemic. Not to say it's perfect, because clearly we don't want a death rate, but we realize that that's part of why the death rate, when you're just looking at numbers, is much lower now. Now, to your original point, which I think is an important one, is why are we doing better now compared to earlier in the pandemic? And it's a multifactorial answer, much of which you were somewhat touching on. So what's different between Italy in March versus Mayo Clinic in July, or many of the academic or hospital centers you are all near right now? And it's many factors. A little bit of it is supply chain. So yes, we do have more vents now. More vents were produced, more vents were moved to the appropriate areas. So a hospital that had far more than it needed gave it to a hospital that maybe only had one or two or didn't have enough. We have a much better understanding of the virus. So we're able to understand who needs oxygen support earlier, who needs other medical support earlier, so that we sometimes are able to avoid intubation because they never got that sick, because we were able to manage it early on. And without a doubt, a large reason is also the medications and our critical care approach to treating the patients. So there are still centers. In fact, there's a study that I think we'll likely touch on later in our discussion out of England that reported that in their hospitalized patients who ended up on a vent, their baseline death rate was 41%. So if you're sick enough to end up on a vent, it was almost, not quite a coin flip, whether you were going to live. That number is extremely high and does not reflect what we're seeing in much of the world, does not reflect what we're seeing in most of the United States, certainly does not reflect what you're seeing at the Mayo Clinic. So it may be that in the national health system, their criteria for getting on a vent, or the kind of staffing they have available in their ICUs, or their access to vents, is still not what it could be.
Yeah.
But if you look at hospitals that have the vents, have the resources, and I'll say quite frankly, it's not a pleasure, but it is a wonderful support at Mayo Clinic that our critical care doctors are just so darn good. And we've learned in 3 months a lot of tricks that you can do in our critical care COVID patients that help them get better faster. And then on top of it, we do have drugs now that we did not have before.
Let's touch on some of those. Touch on some of those drugs, Stacey, and maybe we could start with, of the therapies that we have learned and the tricks that our critical care intensivists are applying. One of the ones that was early on was, we would tell our families with long QT syndrome, for example, that all the therapies that are advancing, that if they work, they're yours. You can take them, you can receive them, except hydroxychloroquine and azithromycin, because those medicines are QT dangerous, especially if somebody has long QT syndrome. And so if those drugs work, great. I hope they do, because that would be supply chain. We can make plenty of it. Efficacy, if the signal is there, fantastic. We'll navigate around the QT issue. We can make this work. But before you receive one of these two medicines, you must get permission from me, meaning our patients. And then a lot has happened.
Yes.
The hydroxychloroquine became the red pill versus the blue pill, and some craziness came around that medicine. But now, 4 months later, is this even a medicine or a combination of medicines that we're using at Mayo Clinic for the hospitalized COVID-19 patient? And maybe now every medicine's available for our long QT patient, because those two are not even on our treatment list anymore. What's the state of that?
I completely agree with you, Mike. I wish they had worked, because it would have been nice. They were oral medications. They're already FDA approved. We know our safety and tolerability in humans, but a robust amount of very well done studies, a robust amount of data in every single area has shown that they do not work. Either hydroxychloroquine alone, azithromycin alone, or the combination. So they are not treatments for SARS-CoV-2 infection. I wish they work, they just don't work. We also know that particularly for hydroxychloroquine, it had been used in another situation, prophylaxis, meaning if I take it every day, will it prevent me from getting the infection? And the data that's been completed so far shows that that is not useful in that setting either. So neither in the prophylaxis nor in the treatment are these shown any efficacy against the virus.
So hydroxychloroquine will soon be back for just our rheumatoid arthritis patients only, and they don't have to worry.
Or lupus patients or malaria,
for which it's really, really safe in them because their QT vulnerability is completely different than a SARS-CoV-2 virus that actually can infect the heart muscle itself and irritate the electrical system itself. But since you also are the principal investigator for several clinical trials of COVID-19 therapies, and I don't want you to give us a sneak peek into what they're showing, but talk to us about some of the other treatments and what you think is the signal so far. Say maybe we take remdesivir, dexamethasone, and plasma or convalescent plasma therapy. Let's do those three.
Sure. So at Mayo, I was the site PI for remdesivir, but I feel very comfortable talking about it because the studies are closed. The preliminary data is released, and it does show efficacy. It's quite frankly the first and only treatment on the planet that went through randomized controlled phase 3 trials that showed efficacy. And as of about a week and a half ago, Gilead, who owns this medication, reported at the International AIDS Conference, which is somewhat of a virology conference, that it shows reduction in mortality as well. So this really is, across the world now, the standard of care. Gilead stopped the studies earlier as soon as the DSMB, or the people monitoring the data, saw any evidence of efficacy. So rather than waiting for every patient to hit their endpoint, they said, you know what, we already see a signal. Let's stop now so we can move forward for approval to get this drug to more people. So the good news is it moved faster. The bad news is the data doesn't look quite as robust because they stopped early. So even what they've reported is probably even better than that as the late data sets come in. So they went to the FDA and got what's called emergency use approval in the United States, which means you can use it under emergency use, meaning people who have the infection, but it's not universally completely FDA approved yet. That will likely happen sometime later in the year. But what happened is Gilead, because of supply issues, gifted their standing supply to the federal government in the United States. The DHHS then divided it between all the states, and every state decided how they were going to give it to the hospitals within their state. They did that for quite a few months, and now they're charging, but it's still being distributed through a mechanism of the US federal government that uses certain criteria on which hospitals get more or less of the remdesivir. So it's not quite enough for everybody. And we certainly can't wait till it's fully FDA approved. But undeniably, remdesivir makes a difference. It is an IV therapy, so it's used for people who are in the hospital. Gilead has turned it into an inhalation therapy, and those trials are about to start. And so we'll see if that works as well. But this is now considered the standard of care. And anything else is either in addition to remdesivir or being investigated alongside remdesivir.
What about dexamethasone? There was a lot of it. There was a lot of news about that steroid 2 weeks ago, and I even saw somebody on the news declaring that nebulized budesonide, which is a type of a steroid, was sort of like the magic bullet. What say you on dexamethasone and versions of that?
So first, I'm going to take a step back and explain what kind of therapies we use at different stages of the disease. So early in the disease is when people have the viral syndrome. That's when you have the muscle aches and the fevers and the cough, if you're going to have symptoms. And it's like having a virus. It's like having the flu or a cold or something. Then right around day 7 to 10 is when you either get better or you trigger what's considered an inappropriate immunologic response to the virus. So the immune system somewhat, and it's not exactly that simple, but it's easier to explain this way, overreacts to the virus, and you get kind of a inflammatory storm. And that storm is what makes you end up in the intensive care unit or on a ventilator, because the immune system's overreacting and damaging the organs and causing other changes. Dexamethasone or steroids modulate the immune system in kind of a big, dirty, sloppy way. It's all sorts of parts of the immune system. Many of the clinical trials that are being run, and we're running many of these at Mayo for COVID, particularly the sick patients, are very, very specific, very, very smart, very, very target immune modulators. So they specifically target the one little teeny part of the immune system that we know SARS-CoV-2 is messing with. And those clinical trials are under placebo-controlled trials, and we don't have finalized data, but many of them are looking very promising. And I think those will absolutely be tools in our toolbox. Steroids is a double-edged sword. It's much sloppier, it's much bigger, hits the immune system in many ways, and frequently can cause damage. So for a long time, steroids really were not an approach to treatment. There was a study that recently came out of Oxford in England, and that's much of the data I quoted earlier, that it was not a randomized placebo-controlled trial, so it cannot completely say efficacy. They saw lower mortality if in the very, very sick patients on a ventilator, they gave them dexamethasone versus standard of care. But they had a population where standard of care had a death rate that far exceeded what many of us have. And so whether or not their standard of care actually translates to our practice really is hard to tell. And so whether this has any effect in a patient that would have had a 9% death risk versus 41%, we may not have seen the efficacy. They did not see any efficacy. And again, the study was not designed for efficacy at stages of illness earlier than that. So because of that, the Infectious Disease Society of America, which is our ID society that puts out guidelines, has said that maybe, the data is not robust, but maybe in the sickest of patients on a ventilator, maybe it makes sense to use dexamethasone. But the data is very clear from that study, as well as many others, that using steroids in any other stage of the illness, it's actually more likely to hurt than help.
Interesting.
And so using steroids, whether they're inhaled or unless the person has asthma or COPD or another reason why they need the steroids, but using it purely for the virus actually is more likely to hurt than help if it's at an earlier stage of the syndrome.
That's great information. And maybe we touch briefly on convalescent plasma therapy. As you know, Dr. Michael Joyner here from Mayo Clinic is point person and sort of center command for the NIH and national trial, where we take patients who've recovered from their infection, recovered from their COVID-19. Now we get their plasma that has the potentially therapeutic antibodies in them to then treat the next sick patient to hopefully help them clear the illness faster. What's the current sense of that therapy?
So it's an exciting area and it's a cool thing to think about, but I think the data, the jury's still out. The data is unknown. And much of it is because of how it was used. So in the United States, the decision at the level of the FDA was not to do it in one of those studies that I told you need for efficacy, a blinded, randomized, placebo-controlled trial, which you could do with convalescent plasma. It would just be a little more infrastructure and a little more difficult. So we have not done it that way. So quite frankly, we really don't know for sure whether it works or not. We do know, thanks to much of the work that my colleagues at Mayo and many other investigators around the country have done, is that it's safe. It doesn't seem to be hurting patients, and it seems to be well tolerated. In England, in Canada, and many other countries, they are doing it with efficacy trials. They are doing double-blinded, placebo-controlled infusions with convalescent plasma, and that will give us the information we need to know whether or not it has efficacy. In the United States, we've done kind of cohort matching of controls to kind of try to make a match, and hopefully that data will be released, and that'll give us a strong indication. It won't be perfect because it's not the randomized study. But I think what we know is that this has been an incredibly exciting area. It doesn't seem to be hurting. It's not the final answer because, as you mentioned, it's antibodies from somebody who recovered. Now, how much antibody is in it? Does every person have the right antibodies? And are antibodies even enough to cause neutralization of this virus? We don't know yet. What I think is also very exciting on that heel is there are companies, and we're actually about to start this trial very, very soon at Mayo, that have developed monoclonal antibodies specifically against SARS-CoV-2. So it's essentially smart plasma. it's saying every human would get this specific antibody that's specifically designed to the virus. Now, again, we don't know yet if antibodies are enough to treat this virus. Some viruses they are, some viruses they're not, and we don't know yet for this one. But I suspect over time, the convalescent plasma was just kind of a temporizing agent until we had these other therapies and until we have the smart antibodies and until we know whether or not antibodies actually work against this virus.
Great. So to summarize those, hydroxychloroquine and azithromycin, which are potentially QT dangerous in long QT, that's on life support. That's basically no more.
Exactly. No more treatment or prophylaxis.
Remdesivir, emergency use authorization drug with excellent data so far, perhaps even better than what the signals show because the studies were stopped early because of the benefit signal.
Yes.
Dexamethasone only if you're really, really, really sick, because otherwise it could potentially do more harm than good. And stay tuned about convalescent plasma. We will get the readout in the next months from the blinded studies done in countries called not quite the United States, because the United States didn't design the study that way.
Right, and we'll get the surrogate from our data from the United States, which will hopefully give us an indication. The one thing I will say as a caveat to your comments, Mike, is even remdesivir, so far nothing's perfect. So we know that remdesivir is not the panacea. It is helpful, it is saving lives, it is useful, but viruses are tough to treat, and so we still need other treatments. And what many of these studies are looking at now is in the virus world, we always know that more is better. So 2 drugs are better than 1. We learned that from hepatitis C. We learned that from HIV. We've learned that from, in many cases, hepatitis B, that 1 drug works for a while, but it's not perfect. But if you give somebody 2 antivirals up front, it works much better. And so many of the trials of the other antivirals are combinations. So 2 antivirals, including remdesivir, and not just the 1.
Well, let's leave the antiviral like remdesivir either as monotherapy or perhaps in combination therapy in the future, and go to what everybody wants to know is, what about the vaccine?
Yeah.
Will there be a vaccine for SARS-CoV-2? It seems like there's hundreds of competitors out there. In the last 2 weeks alone, we heard about Moderna's. We heard last week about Oxford AstraZeneca's vaccine, and now most recently we heard about Pfizer's and how they're going to provide all of that if it works. So what's your take on your bull versus bear outlook on, will there be a vaccine for SARS-CoV-2? And if yes, when do you picture that it realistically is going to be available in the United States?
So that's another great question, and it's going to take me just a little bit of time to answer it accurately. So I sure hope we're going to get a vaccine for this. My fingers are crossed, and I'm holding my breath and, throwing salt over my right shoulder. I'm doing everything, I hope. But let me give you just a little bit of a perspective on vaccines against viruses. So there are essentially 3 buckets. There are the polio and measles vaccines, which are against viruses that are spectacular. They're almost 100% effective. If every human on the planet had these vaccines, then they would literally be eliminated diseases. Then there's the middle bucket of the influenzas, that it's a decent vaccine and it works pretty well and it absolutely saves lives and it helps people, but it's not perfect and we need to be revaccinated every year, and it's not quite as robust as the other 2. And then the third bucket of viruses are the hepatitis C, CMV, HSV, HIV, and quite frankly, most viruses that after decades and billions of dollars of extremely thoughtful, smart science, it just doesn't work. And you just cannot form a vaccine to those viruses. We don't know yet which category this virus is going to fall into. What you have heard in the news is people taking different approaches to developing vaccines and sticking them in a human and saying it's safe and saying it causes an immune response. Quite frankly, that's kind of a low bar. Almost anything that any peptide or anything else, not everything, but most things that you put in a human body will cause an immune response. So the fact that they're seeing an immune response, yeah, we expected that. That's really not a big deal. What matters is if that immune response is capable of preventing infection. And that's what really matters, and that we don't know for anything yet. We don't know if it's even possible. We sure hope so. We expect so. And the vaccines that are coming into trials even later are taking really, really smart approaches to do it in ways that make sense for the immunologic response that we know so far for this virus. But we still don't know if we have what's called efficacy, meaning whether taking this vaccine and getting that immunologic response, which is likely going to happen anyway, is enough to prevent infection. Now, the earlier ones that went in are already in human trials. So do we have vaccines in humans? Yes, we do. They're already in human trials. Whether they will prevent infection is going to take much longer to know. At least 6 months, sometimes even longer, because we don't have a good blood test or a surrogate for vaccine response. Many of the vaccines that went in up front are looking at targeting 1 or 2 parts of the immune system. Hopefully that'll be enough. Maybe it's not. Some of the other vaccines that are taking a little longer to go into humans because they're kind of more complex are actually, in my opinion, really smart approaches. And those vaccines, and there are quite a few of them, will likely enter human trials in the fall. And so will we have vaccines in humans? Absolutely. We already do, and we'll have far more by the end of the year. Will they cause immune responses? Absolutely. We expect that. Will they prevent infection and actually work the way we want a vaccine to work? We have no idea yet. And that data will take, even if it starts a trial in the fall, it'll take at least 6 months, if not longer, till we know efficacy data. Now,
I think that's so important that you said that, Stacey. In fact, I think you're one of the first people I've ever heard so clearly articulate that we actually don't know efficacy signal with any of the SARS-CoV-2 vaccines yet. I've actually never heard anybody say that so point blank.
Yeah, we just don't. We've got our fingers crossed. I sure hope that immune response they triggered and keep reporting in the news is enough to prevent infection, but we just don't know. Now, it's also important to realize that the FDA has a very, very low bar to approve something. Right now, they've got nothing. So if something has a 10% efficacy rate, sure, that's better than nothing. If it has a 50% efficacy rate, that'd actually be quite good. But so even if you see things going forward to emergency use approval or even full approval, it doesn't necessarily mean it's going to get us to where we need to go to make a difference in this pandemic. We would love to have a vaccine that has a high efficacy rate. If it's around the 50 to 60% and you vaccinate the whole world, yes, that will make a difference. If it's only about a 10% efficacy rate, it's going to be tough to make a big difference and really end the pandemic with vaccine alone. So we really need to be, I think, I don't want to use the word cautious, but at least reserved in what this vaccine media is telling us now. Absolutely, we should all hope. I hope many of them work. I hope they all work spectacularly well. I hope SARS-CoV-2 is one of the first buckets that I told you about, but we just don't know.
And because we just don't know, it seems that all of the things that we started the program with, we need to have a concerted, multi-pronged effort. And am I allowed, Stacey? I know you have something quick at the top of the hour. Do we have 5 more minutes?
Sure, absolutely.
You mentioned the buckets. Polio, MMR, great bucket, and we sure hope the SARS vaccine there. Then you said the middle bucket of influenza. I need you to help the listener out there about influenza, because I can't tell you how many times I've heard, what's the big deal about SARS-CoV-2 anyway? I just looked up the statistics. CDC says that for influenza, for which we're all told to get the vaccine, and I get mine every year. I tell all of my patients to get theirs every year, that there are still, despite the vaccine, 9 to 45 million illnesses, 140 to 800,000 hospitalizations, and 12,000 to 60,000 influenza-associated deaths every year for the last decade. So 12 to 60,000. In 6 months in the United States, we're at 140,000 COVID-19 deaths. So that might be part of the answer. Yes. But to the person out there who's still in ostrich head in the sand land of what's the big deal? We don't make a big deal about influenza. Why are we making a big deal about this new guy called, or new gal called SARS-CoV-2? What's truth on that one, Stacey?
So I think it's multifactorial. And I'll just throw out all of them in random order. They're not necessarily in importance, but they all matter, and they're all part of the matrix of why this needs a little more attention. Infectivity and, at least to date, death rate still are higher with this. And both of those are because we just don't have the vaccine yet. There is a vaccine for influenza, which decreases the number of infection. And even if you get the vaccine and still get influenza, you tend to have an attenuated course or not as bad a course. We just don't have that preventive mechanism right now for SARS-CoV-2 for all the reasons I just told you about. I hope we do get there someday, and this may become just like influenza in the future. But until then, this one's kind of running rampant unless we do some personal behavioral changes. The only way we can slow this down is with those behavioral changes. We don't have a vaccine. We don't have perfect treatments yet. We've got good treatments, but not perfect. And so we need to do those behavioral changes to slow it down. And because I've mentioned the death rate and the numbers you were just citing, Mike, this one has killed far more people in a very short period of time. Mm-hmm. And so, worldwide, there are over 600,000 deaths in literally 6.5 months.
Right.
So this one is killing more, and it's infecting a far broader population of people, and it does have a higher death rate, and we don't have a vaccine.
Yeah, and I think it's sobering to think if we didn't have the influenza vaccine, how deadly influenza would be.
Oh, absolutely. And it has been. And the one thing I will say, and again, this is earlier data, but it is data that we've seen a signal enough that I feel comfortable talking about it, is one of the things we're learning about our immune system is there is some cross protection, not mimicry. It's not like SARS-CoV-2 looks like influenza, but in somebody who gets their influenza shot, it primes their immune system in a way that actually probably makes them not have as bad a SARS-CoV-2 disease or not get as much infection. So there's so many reasons to get your flu shot. And there's this sort of interesting signals being seen around a number of vaccines, MMR, a few others, but particularly the influenza vaccine and MMR keep showing up as, again, it's not that this virus looks like the other one and that they're crossing over, but it's that it's priming the immune system in a way that makes you just a little bit more protected against this other virus. So every reason to bring your kids in, to get them on their vaccine schedules, and for every single human on planet Earth to get the influenza vaccine every fall when it's available.
Stacey, thank you. And we're in this for a long haul. I've told our patients and our families at Facebook Live that we're going to have this coexistence with SARS-CoV-2 for quite a while.
Yes.
And so we've got to figure out the battle plan. And could you just leave our Facebook Live community with sort of the 2 to 3 must-dos that they must do if we want to win this and overcome this pandemic together?
Absolutely. Right before I log off, I just want to leave with a few messages. Again, thank you very much for having me be a part of this discussion today. I'm really, truly honored. I think the must-dos are follow the public health measures and behaviors that are recommended. Universal masking in public places, social distancing, good hand washing. We know it works. The data is there. It works. Control your risk factors that can be controlled, such as take care of your health issues, take care of your blood pressure, your diabetes, quit smoking, and if you have a BMI over 30, this is the time to lose weight. And then lastly, just stay engaged. We learn so much so quickly. And yes, sometimes our recommendations change, but part of that is because we learn more and more about this virus every week. So please pay attention to your public health recommendations, stay engaged, and understand why sometimes things change a little bit. And thank you very much.
And thank you, Stacey. And with that, we will do the I mask, you mask, we all mask together. And Stacey, Dr. Stacey Rizza has joined us for the past 40 minutes, and she's got to go. I'm not only her medical school classmate, and I'm not only her neighbor. I have the privilege of being one of her colleagues, as she is truly one of Mayo Clinic's COVID-19 experts. And for your knowledge, for your wisdom, and for taking the time to be with our SADS families here, and then I've seen on the comment line, everywhere from Virginia to Ireland. Dr. Stacey Rizza, thanks so much. And I know you need to sign off, and take care. And for the rest of you out there, thanks for joining us. Share this. The SADS Foundation will put this on their website. Tweet and retweet this and spread this information. I learned some new things, lots of new things. And I learned a perspective to have. And I think knowledge is power. One of my favorite life verses from the Bible is that he has not given us the spirit of fear, but one of power and love and a sound mind. And boy, I think we heard some sound-minded thinking from Dr. Rizza. And so that concludes episode number 21. Join us next week, Friday, July 31st. It's a different start time in SADS Facebook Live land. It's going to be at 11:20 p.m. Central Standard Time, 2 hours earlier. So set your clocks, and I'm going to have the great privilege of interviewing one of my dear friends and one of the true giants in the field of long QT syndrome. I will call him the king of long QT syndrome, none other than my dear friend, Dr. Peter Schwartz from Italy. So you're going to enjoy that interview a lot. And so stay tuned, come back to us next week, show this and play this over, show this today's video to your family, show it to the naysayers, show it to those who still think this virus is much to do about nothing. It is much to do about something. So wake up, people, and do the right things. We need to stay corona-free for as long as we can. I'm trying to. My family's trying to. You with long QT, you're not at any greater risk of COVID-19 than I am. But nevertheless, I want to stay corona-free until we have a vaccine that works, until we have the therapies that work, so that if I'm not one of the asymptomatic ones, and 40% of us would be asymptomatic, I hope that's me if I get it. But if I'm not, I will get effectively treated so that I can be reinstated to life and all of life wholly. So with that, put this on, wear a mask, do it, just do it. We have in the state of Minnesota, starting tomorrow, a Minnesota state mandate from the governor of Minnesota. Why did we need a mandate? Let's just do it. Put the mask on, and let's do this for each other. I mask, you mask, we all mask together. So until next week, stay well, everyone. Refuse to fear. We will overcome this, and we'll see you next week. Bye, everybody.